Good morning. For those of you who don't know me, I'm Dr. Ellen Hartenbach. I'm the chair of obstetrics and gynecology, and I have the privilege of kicking us off this morning for the Women's Health Symposium. And I just, first want to say that this is sort of an amazing symposium that's been going on since 2005 in the department, for those of you who are newer to the department. And every year it gets better and better. So it's my honor to welcome you to the 2022 UW Women's Health and Health Equity Research Lecture and Symposium. Thank you for joining us in person and online for a busy morning of presentations and posters about research that addresses persistent gender, racial, and other health disparities. We have an impressive agenda planned this morning, including an incredibly distinguished keynote speaker and presentations on a wide variety of health equity issues in OBGYN. This morning, we'll kick it off with brief and brilliant talks, which is a new feature in our 2022 symposium. Before we do that, I just really need to stop and thank a few people who put together the symposium. Autumn Hayes is our meeting coordinator. She's done an amazing job. Dr. Katie Sempenny, who's one of the co-chairs of our DEI committee, along with Melody Bachenfeld, our outreach program director, who is also a co-chair of our DEI committee, and Dr. Sarto, who started all of this in the first place. These people, along with an incredible group of dedicated and talented steering committee members, have just done an amazing job putting together this year's conference. So now I would like to call Anastasia Dougherty forward. She's one of our certified nurse midwives, and she's in our division of academic specialists, so general OBGYN, and she's going to introduce the brief and brilliant speakers. Anastasia.
Good morning. As Dr. Hartenbach said, I'm Anastasia Dougherty. I am on the steering committee for today's event. I get to introduce the brief and brilliant speakers this morning. We have 5 speakers today, and they were competitively selected. Can you hear me? Okay. They were competitively selected from many submissions. So we had a lot of submissions to consider, and they will be giving you just a taste. So this is very much like a TEDx style. They only have 3 minutes to just give you a taste of their work. And we really want you to, while you're listening, to think about which one of these 5 excellent presentations really is most compelling to you, makes you want to hear more about their project. So the 5 people that will be speaking today are Fiona Weeks, who is a candidate in population health, Megan Murphy-Belcaster, who is expected to graduate in 2023, Maya Gross, who is a UW senior OB resident, Beverly Hutcherson, who is expected to graduate with her master's in endocrinology and reproductive physiology in this spring, Kristina Warner, who is our UW FP-MRS fellow. And we may need to make an adjustment because our chief resident, Maya Gross, or the senior OB resident, Maya Gross, is not here right now because she was on nights and she's just finishing up rounds. So we may need to make a slight adjustment, but we really want to move right along through the speakers this morning. Right after everyone has spoken, the polls will open. And you have until 8 a.m. to make a choice of which speaker's brief and brilliant presentation is most compelling to you. So think about that while you're listening and enjoy the speakers.
All right, good morning. My name is Fiona Weeks. I'm a doctoral candidate in population health, and I'm going to talk with you this morning about innovations in measuring intrapartum care quality at the population level. We know that quality of healthcare is important for health, including the quality of interactions between the provider and the patient. However, measuring these aspects of care quality can be difficult especially as they pertain to intrapartum care. They are not documented in the birth record or electronic medical records, which make them studying at the population level even more challenging. To address this gap, I leveraged an existing population surveillance system, the Wisconsin Pregnancy Risk Assessment Monitoring System, or PRAMS. PRAMS surveys a probability-based population sample of people who recently gave birth to ask them about their experiences before, during, and shortly after their pregnancies. In Wisconsin, PRAMS uses a race-stratified sample to study racial differences in pregnancy experiences, specifically Black-white differences. In 2020, we added a census of Indigenous birthing people. We also developed a set of new questions on intrapartum care experiences using cognitive interviewing. Using this population representative sample and new questions on intrapartum care quality, I find that non-Hispanic, Indigenous, and Black birthing people are more likely to feel unsafe, feel that their provider withheld information, and feel disrespected by their provider during their labor and delivery, compared with white birthing people. In multivariable regression models, the differences remain significant for Indigenous birthing people. Importantly, my research measures the experiences and perceptions of the birthing people themselves. While providers may not intend to withhold information or show disrespect, these data illustrate that this is unfortunately the experience of many birthing people. We may need to critically examine common practices in provider communication that result in these perceptions. Moreover, the experiences have real implications for birth outcomes, trust in the medical system, and future utilization of healthcare. This is one of the first times we've had data on Indigenous birthing people at the population level. My research suggests a need for increased focus on person-centered intrapartum care, especially for this population. While perinatal care is often focused on making sure the baby is born healthy, how we treat pregnant and birthing people matters too. I think this quote from a PRAMS respondent says it best. I mean, they may say my baby was safe. They just didn't care about my concerns or well-being. We need to do better. Thank you.
Testing. Thanks. Good morning. My name is Megan. I am a fourth-year medical student. I'm Lakota and Choctaw, and I'm a future OBGYN. I'd like to bring us all north of here, just west of Green Bay, to the Oneida Reservation, which overlaps with Brown County. Up here in Brown County, life is a lot like it is down here for you or me. A woman with a pregnancy can go for prenatal care at the Oneida Community Health Center, maybe with our own community partner and prenatal nurse, Candy Cornelius. Hi, Candy, hope you're watching. And she can have her baby at the hospital vaginally or by C-section. Or if she's had a C-section before, she can choose to have a repeat C-section, which actually comes with higher risks of complications than its alternative of vaginal birth after cesarean or VBAC. Now, for reference, the NIH prioritizes VBACs due to its lower risks and better outcomes. So Candy and I first met a couple of springtimes ago where she shared an observation with me. She told me that women in her community didn't seem to be having VBACs, but were instead getting C-sections over and over. Other conversations with Oneida women suggested to me that many didn't even know it was possible to have a vaginal birth after cesarean delivery. So then I, under the gentle guidance of Dr. Heidi Brown, went to the publicly available data to see if this was borne out. And I looked at birth counts stratified by delivery method and race for the last 20 years in that region. So here are those rates for the year 2000. And I'd first like to bring your attention to the American Indian Alaska Native group, where both the VBAC rate and the repeat C-section rate are labeled and are both equally low. Fast forward to 2018, where for the same group, the VBAC rate actually hasn't changed at all, whereas this repeat C-section rate has gone up more than any other demographic in the region. I'll also tell you that every year since 2013, the repeat C-section rate for this group was actually higher than the primary C-section rate or first-time C-section rate every year since 2013. So it turns out Candy was right, that the VBAC rate for American Indian women in Brown County has been stagnant for 2 decades, whereas the repeat C-section rate continues to increase. We know that the maternal morbidity and mortality problem in the United States is driven, at least in part, by increasing C-section rates. Our next steps are to figure out what's happening in Brown County and to make a plan together. Our IRB approved documents are currently under review by the United Business Committee to talk to women, to elevate their voices, and to see what we can learn from a community of women that deserves to see positive change. Thank you. Pilamaye.
Good morning. My project is titled Leveraging Quality Improvement to Promote Health Equity, Prenatal Aspirin Recommendations by Race. Preeclampsia has been identified as one of the most preventable causes of maternal morbidity and mortality. Aspirin in the right patient population can reduce the risk of preeclampsia, preterm birth, and fetal growth restriction. Guidelines for aspirin created by the USPSTF are meant to capture patients with a greater than 8% chance of developing preeclampsia. Non-Hispanic Black race is included as a moderate risk factor, as Black patients are disproportionately affected by preeclampsia and its effects. Our primary objective was to implement a standardized approach to aspirin screening and prescription in an academic OBGYN practice. Secondary objectives included increasing adherence to published guidelines and assessing whether standardization of aspirin screening and prescription resulted in comparable prescription for Black versus non-Black patients. This quality improvement initiative included all new OB patients in our system. We conducted an initial chart review of 200 OB patients and created this workflow, which consisted of nurse-performed telephone screening. Providers were responsible for reviewing the screening, signing the prescription, and discussing the recommendation with the patient. After the initial rollout of the protocol, we conducted monthly PDSA cycles to allow for in-time change throughout our intervention to optimize outcomes. Over the first 8 months, screening occurred in 99% of patients, and we averaged between 80 to 100% compliance with aspirin recommendations. In addition to PDSA cycles, we also conducted a post-intervention analysis of 200 charts. These figures represent results from our entire cohort, not stratified by race. Pre-intervention, 47% of patients overall met criteria for aspirin. And prior to our intervention, among those patients, only 28% of them received a documented recommendation for aspirin. 3 months post-intervention, 48% of patients met criteria and 78% of them received a correct recommendation. When looking specifically at non-Hispanic Black patients in both pre and post-intervention, the vast majority met criteria for aspirin. Pre-intervention, 29% of Black patients meeting criteria received a recommendation for aspirin, while post-intervention, 80% received the same recommendation. Comparing this with our data shown in the previous slide, rates of correct aspirin prescription for Black patients did not differ from rates in the overall population. In light of recent justified critiques of race-based risk calculators, the inclusion of race as a clinical variable guiding treatment decisions should be scrutinized. The recently published journal in the New England Journal of Medicine, Hidden in Plain Sight, provided guidelines when considering inclusion of race in health calculators. Practitioners should question whether the inclusion of race is based on robust evidence and statistical analysis, should consider if there's a plausible causal mechanism for the racial difference that justifies the race correction, and should consider whether implementing a race correction will relieve or exacerbate the health inequity. As this intervention is aimed at decreasing preeclampsia, which disproportionately affects the Black community in both incidence and morbidity, and aspirin is unlikely to cause harm, we do believe the inclusion of race is justified. Our standardized approach to screening and prescription resulted in similar rates of correct prescriptions for aspirin in Black and non-Black patients, suggesting a mechanism for delivering equitable preventative obstetric care. Thank you.
Good morning, everyone. Today, we are going to explore some alternative approaches to tackling the crisis in maternal death of African-American women. African-American women are 4 times more likely to experience pregnancy complications and death during pregnancy and childbirth. The dominant narrative around mortality rates in pregnant African American women conclude that racism drives chronic stress, leading to poor birth outcomes. Given my training in the Endocrinology Reproductive Physiology program, and as an African American woman who has navigated a high-risk pregnancy, I questioned whether this health crisis was being sufficiently evaluated through a biological lens. After further investigation, I noted that the majority of papers and talks by clinicians and non-clinicians alike emphasize racism as causal, with the reduction of bias as a solution. And I began to question, are we saying that we have to completely eliminate racism to save pregnant African American women? Frankly, they don't have time, given the acute nature of pregnancy. So are there alternative approaches that may enable more efficient interventions? From my investigation, 3 themes emerged. Mortality and morbidity rates are studied, but mostly examine correlations, generating hypotheses without actually testing them. Epigenetic reprogramming of offspring without effective intervention will appear in grandchildren, resulting in multi-generational pathology, perpetuating poor birth outcomes. And finally, there's critical research that is absent from the dominant narrative. Well, what research am I referring to? Insight from existing basic science on the origins of adult disease and health, research on pregnancy and pregnancy-induced complications, while salient, are underutilized. Now, let me be clear. My goal is not to minimize the impact of systemic racism, but a clear gap exists in translating the existing research into clinical practice that may allow for preventive medicine models and multi-pronged transgenerational models that lead to deeper understanding and potential interventions that may support both acute and longitudinal solutions to support the longevity of pregnant African American women. Thank you.
Thank you. Good morning. I'll never forget the day that I finished my first year of medical school. The first doctor in my family, although it wasn't graduation, it was a big deal, and I was excited to enjoy my final summer vacation. I remember quick goodbyes, a long, uncomfortable flight home, and then being greeted by my aunt at the airport. My favorite aunt standing there, flailing her arms in the air to greet me. It was a sight to see. It was incredible. The drive home was full of family gossip and storytelling, and it was so much fun. That was until mid-sentence, she paused and the trickling started. The trickling quickly became a brisk stream, and I was uncomfortable, she was uncomfortable, and so we sat there staring at each other for the rest of the drive home. Urinary incontinence is defined as the involuntary leakage of urine with activity, think cough, laugh, sneeze, or with an urge sensation, think gotta go, can't make it. It's a disease that affects men and women, young and old, and it's associated with risk factors such as age, obesity, prior vaginal delivery, race, and ethnicity. Historically underreported and undertreated, urinary incontinence is estimated to affect nearly 60% of women in their lifetime. However, some of this prevalence data doesn't maintain in the African American population. But why is that? How is it that race, a social construct, is supposed to affect urinary incontinence prevalence? We performed a quantitative analysis of data collected by the Survey of the Health of Wisconsin in a predominantly African-American population in Milwaukee, Wisconsin. And we sought to describe urinary incontinence prevalence and care seeking and identify factors associated with urinary incontinence care seeking. Our conclusions were that urinary incontinence was common, affecting nearly 47% of women, that it was associated with age, obesity, and needing help reading medical instructions, that care seeking was more common than in prior studies, and that interestingly, women of non-Hispanic Black race were less likely than any other women to endorse urinary incontinence. And so the next steps of our work are to dig deeper and perform a qualitative study to better understand the lived experiences of women, Black women with urinary incontinence. Thank you.
Okay, everyone. We're going to go ahead and get started. If people could take a minute to get to their seats. I love hearing all this chatter. Everyone, but it's time to wrap up your conversation. I think so. Oh yeah, it is. Yeah, the mic is on. Okay. The mic is on, but there's just so much fabulous conversation.
Yeah, it's not going. Let's try toggling it again.
Testing. That kind of.
Is the mic on?
How about now?
Okay. I think we have attention now. Can you hear me in the back? We're just testing our mic. Oh, somebody raised their hand. That's fabulous. Okay, well, welcome back, everyone. We have had all kinds of great conversation and poster viewing. The posters are fabulous. I just wanted to take a minute to actually read the list of names of the steering committees, the steering committee for this symposium, because those brief and brilliant talks were just brilliant. So in terms of the committee, as I mentioned, Dr. Sarto, Dr. Sempene, Dr. Patenkar, Laura Swan, Anastasia Doherty, Lisa Scott, Carol Holland, Cheryl Casey Grant, Autumn Hayes, Melody Bachenfeld, and Maya Gross. And a quick shout out to Manish Patenkar and Laura Swan. The brief and brilliant talks were their idea. And I thought it was just smashing. And I really just think that the more people we have on the committee each year, the better that we can make the symposium. And just congratulations to the steering committee for what we've had so far. And I'm super excited about what's to come. So I have the pleasure now of introducing our keynote speaker. The keynote presentation for this morning is eligible for CME credit. Text the code YUNFUH to 608-260-7097. And that will also be in the chat, but I just want to say it out loud in case anybody's out there on their phone or doesn't have a screen up. But those are the things to receive credit. Again, the code is YUNFUH. Okay, now that business done, I am super excited to introduce today's amazing keynote speaker, Dr. Vanessa Northington Gamble. Dr. Northington Gamble is the University Professor of Medical Humanities at the George Washington University. She's the first woman and the first Black woman to hold this prestigious endowed faculty position. Dr. Northington Gamble is an internationally recognized expert on the history of American medicine, racial and ethnic disparities in health and healthcare, public health ethics, and bioethics. She has worked to promote equity and justice in medicine and public health throughout her long and distinguished career as a physician, a scholar, and an activist. Her accomplishments are way too many to mention in this brief introduction, but just to mention a few. She is the author of several widely acclaimed publications on the history of race and racism in American medicine. She chaired the Tuskegee Syphilis Study Legacy Committee, which led the efforts to obtain an official presidential apology for this study. She was also the first Black woman appointed and tenured in the University of Wisconsin School of Medicine. She was part of this university from 1988 to the year 2000, and she founded and led the Center for the Study of Race and Ethnicity in Medicine while she was here on campus. I'm so happy she's back in Wisconsin today for this keynote presentation. So please help me welcome Dr. Vanessa Northington Gamble.
Thank you for such a gracious introduction. And as I was talking earlier, is that there were times when I was here at Madison, I was the first Black woman ever in the medical school, not in the department, but in the entire medical school. And for many years, I was the only Black woman at the medical school. And I still remember the first time there was another Black woman who was actually in psychiatry and then OBGYN. So, you got to remember people. But I'm really happy to be here, especially because much of the work that I do now was nurtured here at Wisconsin. And I have fond memories of being here. Sometimes not so fond, but for the most part, fond memories of being here. But before I begin, I just want to thank Jamie Reitz for her work and getting me here. I do a lot of traveling, and my assistant and I, we have a ranking of who's helpful and who's not helpful, and Jamie is at the top. So I just want to point that out because it just made my life so much easier for getting here. So today I'm talking about a Black woman physician who wasn't an OBGYN, but she worked in women's health, and is a part of a book that I'm working on. And I have no disclosures, but today what I'd like to do is provide a personal and professional biography of Dr. Virginia Alexander, who lived from 1899 to 1949, and to examine her work, especially her work in women's health, and also to talk about the efforts of Black women to promote equity and justice in health and healthcare. In March 2015, the New England Journal of Medicine published an essay, #Black Lives Matter, a challenge to the health, a challenge to the medical and public health communities. It was written by Dr. Mary Bassett, who was then New York City Public Health Commissioner, and today is the health commissioner for the state of New York. In this essay, Dr. Bassett powerfully and eloquently wrote of her strong moral and professional obligation to encourage critical dialogue and action on ethics, on issues of racism and health, and urged health professionals, let's not sit on the sidelines. She also wrote, I would like to believe that there are at least 3 types of action through which we can make a difference: critical research, internal reform, and public advocacy. And reflecting on these possibilities, I add to the nearly 2 centuries of calls for critical thinking and action advanced by Black United States physicians and their allies. And as I read this essay, I found these words particularly compelling because Dr. Bassett's words precisely describe the work of Dr. Virginia Alexander, a Black woman physician activist whose biography, as I mentioned, I am writing. Dr. Alexander, who lived from 1899 to 1949, tried to make a difference in the lives of her Black patients and the Black community by critical research, internal reform, and public advocacy. Indeed, one posthumous tribute hailed her as a guardian of the health of Negro women. As a medical and public health historian, Dr. Bassett's words also resonated with me because they underscored that our work today stands on the shoulders of others. However, the work's lies contributions of women and people of color frequently go unrecognized. Virginia Alexander crafted a career that linked medicine, public health, research, anti-racist activism, and religion. This morning, I will examine how she came to construct this pioneering professional life. Her biography helps illuminate the substance and character of past efforts to eliminate racial inequities in health and healthcare, and reminds us of the long, stubborn history of these inequities. Now, in my examination of Virginia Alexander's life, I will not be taking a profiles and courage approach. My goal is not to present her as a two-dimensional, heroic Black woman, but as a complex human being with strengths, triumphs, and accomplishments, but also with frailties, failures, and disappointments. Yes, Dr. Virginia Alexander was a pioneer in social justice, public health, and medicine, but as a friend cautioned her at the beginning of her medical career, you are a pioneer, and their lot is never easy. Before I examine the details of Dr. Alexander's life and career, I want to discuss how I came to write her biography. I first heard about Virginia Alexander from Dr. Helen O. Dickens, who was my mentor when I was a medical student at Penn. An obstetrician and gynecologist, she also served as the Associate Dean of Minority Affairs at Penn and had recruited me to the school. Dr. Dickens, whose father had been born enslaved, graduated from the University of Illinois in 1934. She was the only Black woman in her class of a graduating class of 175. After graduating, she completed postgraduate training in Chicago at Providence Hospital, the first Black hospital in the United States. In 1935, after her training at Providence, she moved to Philadelphia in 1935 to practice with Virginia Alexander. 10 years later, she became the first board-certified first board-certified Black obstetrician gynecologist in Philadelphia. And in 1950, she became the first African-American woman admitted to the American College of Surgeons. When I was in medical school, Dr. Dickens and I often talked about the history of Black women physicians. And it was she who urged me to write Virginia Alexander's story. She thought it would be a good fit, as both Alexander and I had grown up in poor families in Philadelphia and had interest in the social aspects of medicine and public health. Indeed, my book will be dedicated to Dr. Dickens. However, for many years, I was reluctant to write Alexander's biography, in part because I thought and still think that biography is one of the most difficult genres of writing to expertly master. Or perhaps, as a former graduate student here at Wisconsin once told me, writing about African-American women physicians would inevitably involve some self-exploration. My resistance to writing Alexander's biography continued despite several links between our lives. We both love Philadelphia. We are both graduates of the University of Pennsylvania, she from its undergraduate school and I from its graduate school and the medical school. We both lived in Washington, D.C. Her residence was 3 blocks from my former home. We both lived in Alabama. What finally convinced me to write her biography was that I discovered that our ancestors had both been enslaved in Mecklenburg County, Virginia, at plantations that were near each other. In other words, I got slapped around too much by the universe that it was like, it was time to write this biography. Now let's get back to the life and career of Dr. Alexander. Her parents, Hilliard and Virginia Alexander, had been born enslaved in Virginia. Her father in Mecklenburg County and her mother in Essex County. By the late 19th century, they joined the migration of freedmen and freedwomen, including my own ancestors, from the Commonwealth to Philadelphia. The Alexanders relocated to Ward 7, the area analyzed by Dr. W.E.B. Du Bois in his landmark 1899 study, The Philadelphia Negro. Virginia was born on February 4th, 1899, in a racially diverse working class neighborhood in South Philadelphia. Virginia had a hard, scrappled childhood. Her mother had died when she was 4. Her father's finances plummeted after he lost his successful riding academy when she was in her teens. After her mother's death, Virginia and her siblings went to live with their aunt, and there was a very difficult relationship with the aunt. And it was a very contentious and distant relationship. But a few blocks away from her home, she found inspiration and mentorship from Reverend W.E.B. Moore, the activist minister of Zion Baptist Church. Moore first demonstrated to Virginia the critical relationship between religion and racial uplift activities. Virginia graduated with honors from high school in 1917, and both she and her brother Raymond received full academic scholarships to the University of Pennsylvania. Their father strongly supported their educational aspirations because he believed that his lack of education led to him to lose his business. However, their aunt did not share her father's enthusiasm for the Alexander children's educational aspirations. They wanted the siblings to forgo higher education and work to financially contribute to the family. The aunt announced that if they did not heed her wishes, that they were no longer welcome in her home. The siblings desperately wanted to attend college and therefore had to find new homes and employment to support themselves. Virginia's difficult decision to disrupt her family life proved to be the right choice as she flourished at Penn. Some pictures for her at Penn. This is one of my favorite pictures here. It's Virginia with a group of sorority sisters, the Deltas at the quad at Penn. A scholastically gifted student, she received distinguished grades in several subjects. She blazed through Penn and graduated in 3 years, all the while working as many as 20 hours a week as a maid, a waitress, and a clerk. When Virginia Alexander entered the Women's Medical College of Pennsylvania in September 1920, only 65 Black women practiced medicine in the United States, 5 of them in Philadelphia. But Virginia found the road to a medical degree rocky. During her first year of school, she failed all of her final exams, in part because of feelings of marginalization. At Penn, she had been part of a close circle of smart, professionally ambitious Black women. At WMCP, Virginia was the only Black woman in her class and one of the 2 in the entire school. Racial discrimination intensified her feelings of isolation and adversely affected her grades. As a member of the first year class's basketball team, she expected to attend a dance organized by the players. However, faculty members canceled the event when they learned of Alexander's plans to attend. In March 1921, while still navigating her first year in medical school, Virginia's classmates held a minstrel show under the auspices of the Young Women's Christian Association. The event included students performing in blackface as the Gold Dust Twins, the racist caricatures from a washing powder commercial. The program was promoted in the school bulletin and received support from faculty and students, suggesting an unwelcoming racial climate for African-American students. Despite her academic difficulties, she remained at WMCP and continued, and her academic problems never resurfaced. Virginia's activism began while she was still a medical student. In 1924, during her junior year, she led 3 other Black students in a protest against racism at the medical school. They met with the school dean to denounce the racist behavior of an influential professor who enjoyed, she said, telling discreditable, dirty, insulting stories about Black people that whenever there were African Americans in the classrooms. Virginia and her Black classmates contended that they had called the meeting with the dean because, as they put it, our self-respect demanded that we register protests. The dean was not swayed by their grievance and supported the professor. Although the protest was unsuccessful, it marked a milestone in Virginia Alexander's anti-racist activism. Virginia earned a reputation as an earnest, careful, and diligent student. After 5 years of what she described as hard grind at medical school, she received her medical degree on June 3rd, 1925, with 29 other women. By graduation, her professional future appeared bright. A few months earlier, her career prospects had seemed bleak as racism and sexism hampered her search for an internship position, as was the case for most African-American women who graduated from medical school in the first part of the 20th century. When Virginia applied to the publicly financed Philadelphia General Hospital, the hospital's director of health told her that she would not be appointed, even if she was first in 1,000 applicants. Even the internship program operated by the Women's Medical College of Pennsylvania was not an option because it did not admit Black women. When Virginia Alexander and her classmate Mae McCarroll sought an internship at that hospital, a school official acknowledged that the two women had been doing good work, are diligent, and should make good interns, and were deserving of the best that their hospitals offer. In other words, their postgraduate training would have to take place in a Black hospital. School officials worked to get them internships at one. The school's actions underscore what historian David McBride's conclusion about Black women's graduates at the University of, at the Medical College of Pennsylvania were considered colored doctors who would work toward a predetermined future that was worlds apart from the white medical mainstream. Dr. Catherine Berry Richardson, a white woman, women's medical college alumna, assisted Virginia Alexander and Mae McCarroll in their quest for internships. She had strong ties with African-American physicians in the city-operated Kansas City Hospital No. 2, also known as Kansas City Colored Hospital, including its superintendent, Dr. Thomas C. Unthank. The Missouri Hospital had a proud legacy of training Black physicians, but it had never appointed a woman to any position. Unthank initially hesitated to consider the two WMCP graduates because of their gender, a reflection of the discrimination that Black women physicians frequently experienced from Black male physicians. He eventually relented, and Virginia Alexander and Mae McCarroll became the first woman interns at the hospital. After her internship, Virginia stayed in Kansas City to do a pediatrics residency at Wheatley Providence Hospital, another Black hospital in Kansas City. Brimming with professional optimism about her professional prospects, Virginia returned to Philadelphia in 1927. She was ready to go about opening up her medical practice and began the work of improving the health of her North Philadelphia neighborhood. She began providing outpatient care in her home, and in 1930, she renovated her 3-story residence in North Philadelphia to open the Aspirin Health Home, a 3-bed licensed private hospital used primarily for minor surgeries and deliveries. Virginia also provided post-abortion care there to a friend who had had the procedure performed by another physician. That's the license. And here is the exterior of the health home. And there's the interior of the health home. And she also considered Esperanto a teaching center for the provision of health education and birth control. Virginia Alexander viewed her medical practice as inextricably linked to broader social and political concerns. At a time when organized medicine opposed such beliefs, she called her health home a socialized medical practice. To her, that meant it exemplified service to the community and that it would grow into a group practice with shared responsibilities. She also saw the Aspirin Health Home as a medical sanctuary from the racism pervasive in Philadelphia's hospitals. Alexander's patients encountered firsthand the consequences of such discriminatory practices. In one case, a Black family summoned her to examine their severely burned child who had been refused admission at a local hospital. Virginia rushed to the child's side and determined that the child needed immediate care and admitted him to Aspirin. The boy remained there for 4 weeks and then received another 4 weeks of outpatient treatment. She also viewed Aspirin as a place where Black women could be treated with respect during their deliveries. Alexander's medical career blossomed. She maintained a large but by no means lucrative practice. By 1933, she had treated over 2,000 patients in her office or in their homes. At a time when the color line in medicine was so rigid, Alexander maintained a uniquely interracial practice, becoming one of the few Black doctors in Philadelphia to obtain hospital appointment beyond Philadelphia's 2 Black hospitals. Her white colleagues and her Black male colleagues held her in high regard. One white male physician once remarked, "If that woman were to call me up and say that she had a man in labor, I should say, send him, doc, because I'd know she was right." Alexander frequently did not charge her patients, and thus her financial status was often precarious. She was also not a great businesswoman. She had operated the Aspirin Health Home for almost 2 years before she realized that she needed a license. After almost 8 years of work, she declared, "I have accumulated nothing in the way of the world's goods." Alexander found herself burdened by the demands of a growing medical solo practice, and she often worked 16-hour days. She decided that she needed a business partner. In 1935, she hired Helen Dickens, my mentor, who I previously discussed. The 2 women practiced together for 7 years, and Dickens left in order to obtain additional training in obstetrics and gynecology. Many of Alexander's white patients were Quakers. She had initially established ties with members of the Society of Friends while a freshman at Penn, when she walked into a Quaker meeting house. She had grown up in the Baptist church, yet from her very first meeting, Virginia felt spiritual connectedness and found what she later described as worship at its best. Upon returning to Philadelphia after her postgraduate training in Kansas City, for political, social, and spiritual factors, she became a member of the Society of Friends. In September 1930, Virginia became the first Black member of the Race Relations Committee of the Philadelphia Yearly Meeting of Friends. A major goal of the committee was to develop social scientific strategies to analyze and solve racial problems. Since she was not a friend, she had to join as an unofficial member for representing the race. Previously, the committee had excluded African Americans because some members believed they could speak more freely and with greater disinterest as a solely white committee than as a mixed one. Alexander's sincere and abiding friendships with several Quakers had led to her pioneering appointment. At her very first meeting, she gave notice that she would use her new position to urge the group to take action against hospital discrimination. Virginia Alexander's work on the Race Relations Committee influenced her decision to formally become a Quaker. In December 1930, 3 months after she had joined the Race Relations Committee, she applied for membership in the Germantown monthly meeting. As the overseers carefully considered her applications, some worried about future complications from having a Black member, including a potential increase in the number of Black Quakers, the admission of Black children to its school, and the possibility of interracial marriage. Despite these concerns, her application was approved in February 1931. For several years, she was the only Black Quaker in Philadelphia. Alexandra enthusiastically embraced Quakerism and continued to use her connections with the Friends to fight racism in medicine and to advocate for health equity. 80 years before Mary Bassett's New England Journal of Medicine essay, in which she contended that health professionals should undertake critical research in racism and health, Virginia Alexander had already been engaged in such important work. In July 1935, 5 years after her initial appointment to the Race Relations Committee, she guided the direction of the third annual Institute of Race Relations. Alexandra conceived, co-directed, and obtained funding for an interracial team to investigate the social, economic, and health problems of the North Philadelphia community that was so important to Virginia Alexander's life and career. Her work on this project was personal, it was professional, and it was political. This study was a clear example of what we would consider action-oriented research, as she planned to translate her research into practical solutions to address the health problems of African Americans. Alexander wrote most of the project's final 132-page type report, The Social, Economic, and Health Problems of North Philadelphia's Negroes and Their Relation to a Proposed Interracial Public Health Demonstration Center. Writing with articulateness and fire, Alexander used quantitative and qualitative methods to illuminate the status of Black physicians and patients in North Philadelphia. Alexander's study painted a bleak picture of the health of Black Philadelphians. For example, in 1926, Black infants died almost twice as often as whites. 1926, we're still talking about that today. And in 1927, African Americans died of tuberculosis about 6 times the rate of white Philadelphians. Alexander attributed these sobering statistics primarily to social and political factors, such as substandard housing, inadequate education, and unremitting unemployment. Alexander also pointed to racism as a contributing factor for the poor health of Black North Philadelphians. And she graphically documented the role that hospitals' discrimination played in creating and maintaining health inequities. She discovered that many hospitals excluded Black patients or cared for them in separate wards and clinics. Alexander labeled one hospital as outstandingly unfriendly to colored people. She also used the words of Black patients to illuminate the racism they often face as they sought treatment. One woman recounted her experience seeking medical care for her child. "I didn't like St. Luke's and Children's Hospital, and I wouldn't go there again," she said. "The resident doctor called my child a cannibal because she didn't stop chewing gum the minute he asked her to stop." Another described her fears about being involuntarily sterilized if she were admitted in one of the city's hospitals. "I was told to go to Hahnemann for an operation, but I was afraid to go because they always tell you you need an operation when you don't, and then you can't have any more babies." In the 1935 report, Alexander also revealed that the city's Black physicians faced steep obstacles. She discussed how when Black physicians were fortunate enough to receive admitting privileges at Philadelphia's white hospitals, they often encountered hostilities, as she herself knew firsthand. One evening, Virginia went to a dispensary to inquire about a patient. The woman intern who answered the door assumed that she was a patient and chastised her for coming after clinic hours. Virginia was shocked by the discourteous, reproachful attack, she said, that she received from the young physician who did not know her from any other colored woman. After the hostile encounter, she politely thanked the intern, but before she turned on her heels, she proudly and emphatically announced, "I am Dr. Alexander." Virginia considered her reaction a lesson in race relations because she wanted to make plain to the intern that a Black woman could be a physician. She also received a cold reception at Jefferson Hospital because of her race. She discovered that most of the staff at Jefferson Hospital, including nurses and elevator operators, were ungracious and seemed unable to rise to the situation of having an ordinarily civil or professional relationship with a colored doctor. Alexander's research and clinical experiences expanded her awareness of the lack of public health facilities and training for African Americans in Philadelphia, and she recommended that there be an international health center to serve as a focus for public health activities in Philadelphia. It never was built, but that she used this this proposal to get attention to the inequities in health and healthcare in Philadelphia. The 1935 North Philadelphia study highlighted the exclusion of Black health professionals from the city's exclusion of Black professionals from the 3 city hospitals, including Philadelphia General Hospital. As a member of the Friends Race Relations Committee said, Alexander had forcibly brought the problem of health hospital discrimination to the predominantly white Race Relations Committee and successfully lobbied them to take action. Between 1937 and 1940, Philadelphia General Hospital appointed 3 African Americans to its staff. One committee member described that this was largely because of Virginia's firm but reconciling approach. Hospital doors were open that had been shut. However, Alexander failed in an earlier effort to get Friends Hospital, a Quaker-operated mental institution, to reverse its exclusionary admission policies and admit one of her patients. Alexander's family would later become a target of racial discrimination from Quakers in Philadelphia. In February 1930, she applied to get her three-year-old niece, who was her goddaughter, admitted to the school affiliated with her friend's meeting. The admissions committee, however, rejected the application because they said the time has not yet come for the natural, happy, and helpful admission of Negro children in our school. Members of the committee feared that desegregation of their school would jeopardize the school's financial stability. The financial concern was well-founded. The previous year, another Friends school had experienced a large decline, a large deficit, because several families had withdrawn its children because of the admission of a Black student. In an April 1938 meeting that Alexander described as neither easy nor pleasant, the admissions committee revealed its decision. She cried as she heard that the school had rejected her niece solely because of her race. "I wept," she lamented, as one would weep when one began to realize her helplessness in a situation which one had felt was solvable here and now, solvable through courageous, earnest seeking. Committee members hoped that she would persevere with her friendly association and contact, and she did. However, the rejection embraced her with profound grief. 11 days after the meeting, she wrote her funeral wishes on the back of an envelope. She wanted a Quaker-style memorial, but not in a meeting house. In a letter to her sister-in-law describing this painful meeting, Virginia concluded it by saying, "How long and why, why?" The Quaker rejection of Virginia's patient and niece explode the image of the mythic Quaker as an unwavering champion of racial justice. As I have researched Virginia's life, I have struggled with the question, why after this painful incident with her niece did she remain a Quaker? But perhaps that is not the right question and says more about me than it does about Virginia Alexander. A more appropriate question might be, what attracted her to Quakerism, especially at a time when most African Americans, including her family members, embrace Black religious culture? I think that her membership in the Society of Friends allowed her to craft a career that linked her religious affiliation, public health research, and anti-racist activism. Virginia Alexander's religious faith spiritually sustained her throughout her remarkable career. Indeed, Quakerism suited her religious temperament. She contended that its silent meditations offered her spiritual renewal and perfection in prayer. Virginia once declared, "Try if I would, I could not overcome the influence of Quakerism." She said that that painful episode of her niece's rejection from Germantown Friends School had caused her to lose her zest for her meeting, but made plain that the substance of my faith is very, very real to me. Thus, Virginia made a distinction between the principles of Quakerism and the actions of individual Quakers. Despite the racism in their own ranks, the Quakers maintained two of the few predominantly white committees that attempted to solve the problems of racial discrimination in Philadelphia: the Race Relations Committee and the Philadelphia Friends Service Committee. Alexander served on both committees. If she were to leave the Quakers, she would lose an important arena in which to fight racism and influence the racial attitudes of white Americans. In her work, Virginia frequently bore witness to the humiliation and pain that she suffered as a Black woman physician to influence the racial attitudes of white people, especially Quakers, and to prompt them into action. Marjorie Penny, a white friend and patient of Dr. Alexander's, who operated a settlement house, called Alexander her conscience. She observed that although the African American community needed Dr. Alexander, the white one needed her even more because of her poise and patience and skill, constituted reproaches to prejudice. Penny described her reaction of hearing Virginia talk about her experiences as a Black woman physician. Back in 1932, she wrote, "I heard Virginia tell simply and without rancor of her experiences as a colored woman doctor. That was an expensive evening for me. It cost me my peace of mind that any creature, let alone one so gifted, should suffer so, made me angry. I was ashamed to speak to her at the close of the meeting. As evidence of the possibilities of Alexander's moral suasion, her quiet but powerful testimony spurred Penny to work at promoting interracial understanding and eliminating racial prejudices. As Alexander's career advanced, she increasingly focused on the role that social factors played in the health of African Americans. Her interests reflected in part the intellectual influence of the prominent sociologist and civil rights activist, Dr. W.E.B. Du Bois, with whom she had begun an intimate relationship in the early 1930s. Intimate relationship, okay. I saw some looks like, yeah. It is not clear how long Virginia and Du Bois maintained their relationship, but they remained close friends until her death, at which he telegrammed her family conveying his deepest sorrow at the death of Virginia, my long loved friend. Du Bois had several extramarital affairs, But his biographer, David Levering Lewis, has called his relationship with Virginia one of his most deepest and most enduring. Du Bois had contended, most notably in his work, his 1906 work, The Health and Physique of the Negro American, that racial health inequities stem primarily from social, economic, and sanitary conditions, and not, as was then widely believed, from inherent racial traits. Du Bois's emphasis on the connection between rigorous scholarship and social activism is clearly reflected in Alexandra's work. She also completed graduate work in sociology at Penn in response to Du Bois's urging. However, influenced by her work in North Philadelphia, she decided that disciplined study and research in public health was more fitting for her professional ambitions and applied to the doctoral program at Yale. She immediately encountered obstacles. First, a foundation rejected her application, and then Dr. C.E.A. Winslow, a prominent public health leader and chair of the Department of Yale's of Public Health at Yale, notified her that she did not have the prerequisites for admission. Alexander recognized that few public health appointments existed for African Americans, especially women. Nonetheless, she remained tenacious. She secured a loan from a Quaker friend and convinced Winslow of her qualifications. And in October 1936, she became the first African American to study public health at Yale. But ill health forced her to leave Yale after 1 year. For at least 3 years prior to her matriculation at Yale, Virginia had suffered intermittently from vague symptoms such as rheumatism and fatigue. Her health deteriorated at Yale, and in March 1937, she was admitted to New Haven Hospital after the acute onset of diarrhea, anorexia, fatigue, and shoulder pain. Her symptoms abruptly subsided, and she was discharged after 3 days. 4 months later, she was admitted to the hospital of the University of Pennsylvania with similar symptoms, and she was diagnosed with lupus. The disease, with its characteristic periods of remission and relapse, would constantly plague Virginia with both its chronic and acute manifestations. Often her face erupted intermittently with the butterfly rash of lupus. She frequently suffered from fatigue and pain in her legs. Alexandra's medical connections enabled her to receive cutting-edge therapy by pioneering physicians in treating the disease. But their armamentarium against disease still had a 90% mortality rate 5 years after diagnosis. The treatments included frequent blood transfusions, testosterone, bismuth, gold, bed rest, and sulfur drugs. Alexandra was hospitalized several times because of her disease. During a 14-month period between 1937 and 1938, she was admitted 3 times. Lupus also wreaked havoc on her financial situation. The cost of hospital insurance and expensive medications continuously threatened to topple her already unsteady financial situation. There were also times where she should have stopped working, but continued to do so because she needed the money and feared that a prolonged absence from work would jeopardize her professionally. Ultimately, Alexandra's disease precipitated a major personal decision. In 1937, she moved to Washington, D.C., and what she called her voluntary exile from her beloved Philadelphia, an exile that lasted 8 years. She did not feel that she had the stamina to maintain a private practice and did not want her family to see her, as she put it, so dull and incapable. She accepted a position as assistant university physician for women students at Howard University, where she worked under the supervision of Dr. Paul Corneli, another physician activist and public health researcher who in 1934 became the first African American to receive a doctorate in public health. In 1969, he became the first Black president of the American Public Health Association. In 1939, Corneli and Alexander co-authored an article that analyzed the wide gap in the health status between Black and white Americans. Their proposed solutions included the desegregation of health facilities, the creation of public health activities targeted to the Black community, and the passage of the 1939 National Health Bill, which included a plan for national health insurance. Also in 1939, in addition to her Howard activities, Alexander became a physician for the National Youth Administration, a New Deal agency established to provide education, jobs, recreation, and counseling for unemployed youths. In 1941, after writing her thesis on the health status of African Americans who worked for the National Youth Administration, she finally received her master's degree in public health from Yale and became the first Black woman to receive a degree from the medical school at Yale. 6 years later, in 1948, Beatrix McCleary became the first Black woman to receive a medical degree from the school. Alexander left Washington in 1943 and for 2 years worked as a civilian medical officer in the United States Public Health Service at the Schlossfield Clinic in Birmingham, Alabama. She practiced in the venereal disease, birth control, maternal, and child health clinics at a public health center. Virginia Alexander's activism, public health training, and research placed her at the vanguard of Black public health professionals and led to a highly regarded reputation, especially regarding women's health. For example, in January 1938, the Children's Bureau invited her to be a delegate to its conference on improving the health of women and children, especially African Americans. Edward Lewis, who was director of the Baltimore Urban League, harshly criticized the Bureau for failing to invite any of the Black attendees to speak. He contended that if Alexander had been allowed to present her research, she would have given some extraordinary insights on infant and maternal mortality as far as colored people are concerned. Virginia returned to Philadelphia in 1945, only to resume a limited practice because of resurgent poor health. She once again became a member of the Friends Race Relations Committee, and although she remained a committed Quaker, towards the end of her life, she began to express impatience about the continuing plight of African Americans and doubts about Quaker methods to advance racial equality. On Independence Day, 1944, while at the Mayo Clinic for treatment of her lupus, Virginia wrote a letter in which she described the racism that she had encountered in Rochester. Hotels barred her and restaurants refused to serve her. She also discussed her impatience with the continuing plight of African Americans and the limitations of Quaker methods to address the problem. She wrote, "I am thinking up a new technique for handling such discriminatory situations, and is not a Quakerly way, nor one that I could adapt. But it seems to me that others of us who become unwilling to go the slower way of conference, arbitration, and power of the ballot methods may have to resort to an underground sabotage method that will make discriminating classes feel the immediate cost of hatred and discriminatory measures. North, south, east, or west, we are having a rotten experience." However, her frustration did not lead her to abandon her belief in either interracial cooperation or Quakerism. The last years of Virginia Alexander's life were dominated by her battle with lupus. She died from the disease at the age of 50 on July 24th, 1949. Although she had lived with lupus for over 13 years, she tried not to let it interfere with her work. Indeed, there were times when she woefully neglected her health. Her sister-in-law urged her to take better care of herself because the social problems that confront you, and me cannot be solved in our generation. However, Virginia continued working, and 2 months after writing the letter from Rochester, she was critically ill, suffering from pneumonia, sepsis, and severe anemia. During a 14-day hospitalization, her family feared that she would die, especially because, as one of her physicians told her, no one knows the cause of the disease, and therefore we do not know how to treat it. In the decades after Alexander's death, most notably within the past 30 years, there has been a burgeoning interest in the United States in eliminating racial and ethnic inequities in health and healthcare. At the same time, there have been a growing discussion about the public roles and professional obligations of physicians and other health professionals in tackling social ills. The biography of Virginia Alexander sheds historical light on both issues. Her story reminds us that efforts to address these stubborn inequities have had a long history, and her career provides insights into the substance and character of past efforts to eliminate racial and ethnic disparities. Virginia Alexander saw her medical practice as inextricably linked to broader social and political concerns and crafted her career accordingly. She understood that the improvement of the health of African Americans could not be limited to the medical profession. It would take a broad-based effort that would involve not only medicine, but civic and religious organizations, political activism, research, and public health. Until her death, Virginia Alexander remained a champion for justice in healthcare. 6 weeks before her final hospitalization, she attended her last Race Relations Committee meeting. Almost 20 years after she had first brought the issue before the committee, the agenda included a discussion about strategies to combat hospital segregation, a fitting tribute to her influence and tenacity. On October 27th, 1940, 9 years before her death, the Philadelphia Institute of Negro Health honored Virginia Alexander in a ceremony held in her native Philadelphia. The Institute recognized her work in operating her small hospital and in heading the investigation of the social, political, and health problems of Black residents of North Philadelphia. And its coverage of the event, her hometown newspaper, the Philadelphia Inquirer, praised Dr. Alexander as one of the country's most prominent Black physicians and noted that Black health leaders in Philadelphia considered her their foremost worker in public health. Indeed, the award bestowed on Virginia was in recognition of outstanding services to Negro health. What a fitting tribute to Dr. Virginia M. Alexander, a passionate advocate for health equity long before it reached prominence as a national public health issue. Thank you very much.
Don't you stay? Yes, yes. Wow, everyone. That was just fabulous. And the lesson of critical research, internal reform, and public health advocacy for health equity is just, it's just the truth. And this woman's story, and thank you so much for telling it so eloquently, is really a lesson for all of us. We started about 5 minutes late, so I think we'll extend a little bit of time for Q&A. And I want to open it for Q&A in the audience and online. I will kind of take a look at the chat, or perhaps Lisa can. But first, let's just start and see if we have a question out in the audience for Dr. Northington Gamble.
Thank you so much. I guess as I was listening to you talk about the groups that she was working with, the white-led group she was working with, I was just so struck by the parallels to today. Groups that were working on inequities or stated they were working on inequities. and the kind of reception that she had and the resistance to that leadership. And I guess kind of reflecting that in a lot of ways, you know, the more things change, the more they stay the same. And just wondering your thoughts about a lot of health equity efforts today and some of these same issues.
I mean, one of the things that I wanted to present, one is I think a lot of times recently, the discussions about health equity makes it like it's just a contemporary issue. And so I wanted to show that there has been a long history of people trying to battle these inequities. And that, you know, she didn't have some accomplishments in this area, but as I pointed out, we're still grappling with the issue of infant mortality in the Black community. So that there are similarities, but there are differences here. It was not a broad-based movement. There were people who were, you know, working in, you know, looking at inequities. But the other thing too is that one of the things that Black people were able to do, in large part because of racism, is that there were so few Black physicians, there were so few Black social workers, there were so few Black nurses, that people were working together in their women's groups, in their sororities. And so that these groups working together, they worked together because there were so few in different professions. And so one of the things when I started doing my work in health equity, I was working only with the health people, then maybe some of the public health people, you know, medicine and public health. But what we're finding today is that the health people have to work with the criminal justice people, have to work with the income inequality people, have to work with the education people, so that the importance of having it broad-based and interdisciplinary, you know, I think is something that her work showed, but I think today we see that more, it's much more common today.
Great. Other questions from the audience? Here we have a little bit, I'm going to just
Okay.
do a little bit from the chat. So we want to keep those people engaged. Abby Cutler says, thank you so much for sharing this remarkable history and story. And Emil H, a wonderful talk. Thank you so much, Dr. Northington Gamble. Okay,
Thank you.
in the audience.
Thank you so much, Dr. Northington Gamble, for excavating this important history. I wondered whether there was any indication in the research that you've done as to whether the death of Dr. Alexander's mother at such an early age in her life had any influence on her sort of professional trajectory in medicine, or if you'd seen other indications of other events early on that might have stimulated her interest in medicine.
Great question. Yes, I have an answer to that. And one of the things that I didn't have time to go through a lot is that she was a birth control advocate. She had a free clinic in her at her health home. When she was in Alabama, she was involved with, you know, providing, you know, what they call child spacing techniques. She also wrote an article about looking at birth control and preventive medicine. So her mother had 5 children, you know, within, you know, a short period of time. And she writes in that article about women who had children and with this certain, you know, short intervals of time, how that adversely affected their health. And that with birth control, if they space their births, maybe it could help them with their general health. So that's the only thing that I see where she basically talks about, you know, where you see the link between her mother and her career. Now, one of the interesting things about Virginia Alexander becoming a physician is that when she entered Penn, she had wanted to be a teacher and had gone towards being a teacher. And then there was a scholarship that this benefactor was giving for someone to study at Women's Medical College of Pennsylvania. It was offered to her future sister-in-law who wanted to go to law school, who did go to law school. And so she urged Virginia to apply for the scholarship. So that's the first time I ever saw any interest in her in medicine, because she wanted to take advantage of the scholarship. But once she decided to become a physician, she was all in.
Great. Beverly?
Go.
Dr. Northington Gamble, thank you for the presentation. I can see the influence of her life in your life. And now that you've written or have started writing the biography, what impact has that had on you?
Well, it's one of the things where it's had a great, I really resisted. And I was talking about, I was just like, finally, the universe said, okay. I think it is what the impact has had on my life is one that, and there's a part of me, I'm from Philadelphia, she's from Philadelphia, and I'm just like proud of her. I'm proud that that I see myself as one of her children, if you will. But at the same time, the impact she's had on my life is that the journey, to see the journey, and it was not easy for her. It was, it was definitely between her health, people doubting her, but she kept going. And so so for me, it's like, it helps me like to keep going, that, I stand on her shoulders. But the other thing for me is that when I was talking about being here in Madison, one of the things that's gotten lost in the history is that in 1996, I started one of the first centers ever in the country on the history of that looked at health inequities. It was called the Center for the Study of Race and Ethnicity in Medicine. And this is 1996. And that this firm belief that this was the right way to go. And that's one of the things I've learned from Virginia. It's the right way to go. But then the other thing that she has done for me is to make me understand, this is what I've been put on the earth to do, to tell these stories of these folks who people don't know about, and to make sure that they are not forgotten.
Wow. Thank you so much for that.
I think Gloria had a question.
Okay, Gloria, this is our last question, so we can get people.
So I just want to, it's wonderful, wonderful presentation. But we had, I was wondering if you know Gloria Johnson Powell during the time that you were here.
She came after I did.
Okay, because I think she did a lot. We need a lot more perhaps, but she did a lot in at least bringing some information about health disparities, and also was involved in the original meetings that we used to have to discuss those things.
Right. So there's been, lots of people who have contributed to this discussion. And I think it's important to make sure that, people, get their props.
Absolutely. Absolutely. Well, I want to just do one more round of applause, but before that, after that.
I have one more question.
All right, I'm working on learning this chair thing. Okay. So we now have 13 minutes. We're going to come back here at 9:20 for Dr. Aguilera's presentation. So far, a fabulous morning, couple hours, and we have a little bit more. And I want to thank you again for coming back to Madison. These stories are important. On the one hand, same issues, different century. On the other hand, to just be in a room full of people who care so much about this issue, and to learn a little bit more about what's been done and what needs to be done. Very, very important for all of us. Thank you so much.
All right. Thank you all for joining us again. I have to say, this has been an amazing set of presentations so far. I'm looking forward to our last two presentations.
Before I introduce Guadalupe Aguilera, I wanted to share just a little bit about the Health Disparities Research Scholars Program, of which Dr. Aguilera is a part. The HDRS program was started here at UW-Madison by Dr. Gloria Sarto in 2007 and is funded by the Eunice Kennedy Shriver National Institute of Child Health and Human Development. In the time that it's been around, it has provided training at the postdoctoral level to nearly 36 scholars in interdisciplinary research that addresses disparities in health status and health outcomes among minority populations, with a particular focus on maternal, child, adolescent, and family health. So with no further ado, Dr. Aguilera is a postdoctoral trainee in this program. She joined the program in fall 2021 after completing her PhD in sociology at the University of Utah. Her current research focuses on foreign-born persons' multi-country socialization experiences across generations to understand nativity-based differences in population-level fertility trends and life course perspectives to address perinatal health and family well-being. She has received a grant from the University of Wisconsin-Madison Prevention Research Center to support expanding this work in the coming year. And here is Dr. Aguilera. She is with us virtually, so everyone in our audience can see the audience watching her presentation. Yes.
Hey everyone, good morning, and thank you, Lisa, so much for your introduction. And everybody, thank you for being here with me today. Today I'm addressing gaps in long-term care needs after stillbirth and focusing on mental health, the family, and material well-being among foreign-born persons. I will give a review of existing research that motivates my inquiries into long-term care after stillbirth and the current directions in my own research. So the invisible death, stillbirth or fetal loss at 20 weeks or later has been referred to as the invisible death or a silent loss because we lack social recognition of this event as a loss of life, including rituals for mourning and connecting with and comforting those that have experienced this loss. But parents and families, especially the birthing parent, not only suffer the loss of their baby that they were expecting, but they also endure the shock and trauma of diagnosis, delivery, and long-term health and economic consequences. Today, my review will focus on mental health and economic consequences. And I focus on foreign-born persons because of global disparities, but also because of my experience with community-based participatory research, working with a community clinic that serves low-income people and those without insurance also, many of whom are foreign-born. I myself am also a second-generation immigrant, meaning that my parents are immigrants. And the stillbirths of people very close to me also make this topic very near and dear to me. So mental health long-term consequences following stillbirth. Most research focuses on the causes of stillbirth because we want to prevent stillbirth and address disparities, but we also know a lot about the consequences of this devastating event. Compared to live births after a stillbirth, birthing parents are more likely to suffer anxiety, depression, post-traumatic stress disorder, and also psychiatric morbidities that involve hospitalization, including suicide attempts and substance misuse. 2/3 of parents go on to have a future pregnancy, often within the first year after their stillbirth. However, in those pregnancies, there's greater likelihood of experiencing anxiety and depression, which ultimately disrupts prenatal bonding and parent-child attachment for fear of losing the baby. Additionally, parents that experience a stillbirth are more likely to experience future stillbirths, so the long-term effects can truly accumulate over the life course for some individuals. In the context of the COVID-19 pandemic, long-term consequences may have been exacerbated especially for parents of stillborn babies that delivered during the peak of social distancing, when patients were largely isolated and hospitals limited visitors. So taken together, the US prevalence of one stillbirth in every 175 births is much more than a single occurrence and involves many more people than the birthing parent and their baby for a much longer period of time than the time spent in the hospital. Though my focus is on mental health, I want to at least also mention that postpartum readmission is higher among those that experience a stillbirth versus a live birth, and their hospital readmissions are most common for uterine infections, pelvic inflammatory disease, urinary tract infections, and hypertensive disorders. So I very much so look forward to our next speakers that will touch on some of these subjects, and also thank Dr. Northington Gamble and our brief and brilliant speakers for discussing some of these different aspects of disparities in maternal morbidity and the long history thereof. And for anyone interested, these are some references. Financial costs of stillbirth are related to higher cost deliveries, often because of maternal complications, but costs can extend into the long term because of greater surveillance in future pregnancies and the associated higher costs. Research also indicates lower lifetime earnings among those that experience stillbirth because of interruptions in employment related bereavement, related to the bereavement process. For example, it may be difficult for a person to return to spaces such as the workplace where a baby was once publicly expected. Navigating sick days or parental leave may also indicate lower earnings if a person doesn't have paid time off. So a focus on foreign-born persons. Across high-income countries, research finds that foreign-born people experience stillbirth more commonly than native-born counterparts. And to summarize this research, across 31 studies, a systematic review and meta-analysis indicates 35% greater odds of stillbirth among foreign-born persons compared to native-born individuals in these 9 countries listed here. In the US, evidence is mixed. Overall, foreign-born persons in the US have lower stillbirth risk compared to US-born non-Hispanic counterparts, but there's variation by national origin and in some cases by state. Higher stillbirth likelihoods are found among Asian, Indian, Mexican, Black, Puerto Rican, and Somali women. In Minnesota, the likelihood of a stillbirth is overall higher among the foreign-born, but particularly so among women from Liberia. And thinking globally to emphasize that the foreign-born experience may represent unique factors affecting health, across 6 high-income countries, the diaspora of Somali women experiences 86% greater odds of stillbirth. Research on stillbirth-related mental health care. Research and guidance aimed at alleviating the mental health consequences after a stillbirth are almost exclusively focused in the delivery room setting. And they include things like holding the baby and using clear communication with the parents from the time of the ultrasound through to the delivery and beyond. Also an emphasis on the human factor and using methods also used with cancer patients, such as compassionate silence, and simply being and sitting with the parent when grief is expressed. Genuine expression and acknowledgement of the experience as profoundly more than a medical event can help parents make memories that help them make sense of their loss. Research recommends using language that the parents use when referring to their baby or referring to themselves. For example, if the parents use the baby's name, then use the baby's name. Or if they speak of themselves as parents, if it's their first birth, then acknowledging them as such. When 24% of stillbirths have no possible or probable cause, these gestures can make a difference for the memories that stay with the parents. Although we know a lot about the mental health consequences of stillbirth, we lack a model of long-term care, and most care is focused around the immediate event. But a need is generally acknowledged for culturally sensitive care. And I want to give one example of preliminary research presented at a conference that I attended. After a stillbirth, a mother returned to the hospital for her placenta because in her culture, the placenta is buried on the home property. But in tracking down the location of the placenta, the hospital personnel jokingly referred to the placenta as being lost in placenta heaven, which shows general insensitivity to the loss of her baby and carelessness toward the great deal and flooding of emotions that it may have taken this mother to simply show up at the hospital to follow through with rituals honoring her baby. Initiating qualitative research. Toward this end of enriching the care that we can provide parents that experience a stillbirth, I've recently received funding from the Prevention Research Center here at UW to conduct interviews. My objective is to identify the long-term care needs of foreign-born persons after a stillbirth experience using semi-structured in-depth interviews focused on mental health, the family, and economic well-being. And my two aims are to collect the qualitative data and to analyze the data. My broader goal is to develop a program for families that have experienced stillbirth. And I see my current project as a starting point where I can eventually build up to an inclusive model or program for anybody that has experienced a stillbirth, but especially low-income individuals. And I want to make this a program equipped for a range of experiences and backgrounds. And I want to share the story of Chrissy Teigen and John Legend, two famous celebrities that experienced a stillbirth a little over 2 years ago. Chrissy has been very public on social media about her baby Jack and has shared about her experience with alcohol and getting therapy and being sober. She's also shared the ceremony that she finally held for her baby a year after her loss. And she has shared about her journey to her current pregnancy. As someone that likely has the resources to seek care from professionals at any moment of her choosing, her story still shows the ups and downs and the long-term emotional and psychological processing that happens after a stillbirth. The study of associated risks of stillbirth, which is a 2018 special project of the Pregnancy Risk Assessment Monitoring System, or PRAMS, shows that 48% of parents did not seek grief counseling in the months following their stillbirth. And there are a variety of reasons as to why not, including no insurance to cover the costs and lack of information for finding counseling and support resources. A program dedicated to long-term care after stillbirth could provide many of the missing links, especially for low-income families who may go through similar processes as Chrissy Teigen and John Legend, but without any formal support or insufficient support in their times of greatest need. And I see a home visiting program as ideal because of the support for the family overall, including children. But first, the research. To inform my qualitative research efforts, I've been analyzing US births and fetal deaths for 2019. We know of the vast disparities in stillbirth rates among Black parents and American Indian and Alaska Natives, but evidence of high stillbirth rates among Native Hawaiians and Pacific Islanders is also accumulating. I analyzed the role of nativity across race, ethnicity in stillbirths in 2019. Here are the proportion of births that occurred in 2019 by race and ethnicity. Each section shows stillbirth frequencies for non-Hispanic groups and Hispanics on the right. Most stillbirths were to white, Black, and Hispanic women. While for white women, this partly reflects the total births experience in 2019, we know that high numbers among Black women are a disproportionate share. And we see evidence of this in the stillbirth rates per 1,000 total births. This bar graph displays stillbirth rates per 1,000 total births. Stillbirth rates are highest among Black, American Indian and Alaska Native, and Native Hawaiian and Pacific Islander parents. But how would these rates vary when we consider nativity? What is displayed here are stillbirth rates per 1,000 total births by race and ethnicity, but broken down, or by race, race, ethnicity broken down by nativity. US born at the top, foreign born in the middle, and those of unknown nativity at the bottom. When nativity is considered, it stands out that foreign-born Asian and Native Hawaiian and Pacific Islander stillbirth rates are higher compared to US-born counterparts. Indeed, in 2019, most stillbirth occurrences among Asian and Native Hawaiian and Pacific Islanders were to foreign-born persons, which also reflects the nativity composition of all births for these groups. But the takeaway from my qualitative study is to include foreign-born persons of Asian and Native Hawaiian and Pacific Islander origins in my research, because most stillbirths among these groups are to foreign-born persons, and this is true for the 5 years leading up to 2019. And points of further inquiry. Research tells us that stillbirth aggregates in families. That is, the odds of a stillbirth are higher for first, second, and third degree family members of parents that experience a stillbirth. One unanswered question for me is about the second generation. If we know that stillbirth aggregates in families, would stillbirth rates of the second generation resemble those of the immigrant generation? If we know this group differs in many ways from US-born people of third or later generation, we know that this group differs in many ways from US-born people of third or later generations, but could US-born stillbirth rates be driven by stillbirths among the second generation for some groups? To me, this matters for delivering the highest quality person-centered care that we possibly can. To wrap up, we have plentiful evidence of long-term consequences of stillbirth, but we lack an evidence-based model of long-term care. A culturally sensitive model of long-term care could benefit from research on the experiences of foreign-born persons. Among Asian and Native Hawaiian and Pacific Islanders, most stillbirths occur among the foreign-born, and rates are higher among some national origin groups. Yet we don't know the extent to which our knowledge on the long-term mental health and economic consequences are the same, lesser, or more severe for foreign-born parents. Qualitative research can give us insight into the stillbirth experiences of foreign-born people and their resources and their sources of support for returning to daily life after such a life-changing event. For now, we can at least embrace current knowledge in the delivery room setting about the human factor and remembering to slow down and recognize stillbirth as profoundly more than a medical event. Thank you so much. Acknowledgements. I received support from the HDRS program and also from the Center for Demography and Ecology, and my references.
Thank you, Dr. Aguilera. And now we can open it up for questions, either from our in-person audience or our virtual audience.
Good morning. Thank you so much for that great talk. I was just wondering what was coming to mind as you were talking about this is a couple of things. One was I'm imagining you might already be connected with Dr. Sharp in the Hope After Loss clinic. And I can just see a lot of parallels in the work that you're doing and the Hope After Loss program. My other thought that was coming to mind throughout this was how you laid out that it was really important for folks to identify the baby, how the parents would want to be identified. And I think that's, as a clinician, something that I probably don't always do very well. And I'm wondering if there's research or if you would recommend, many times we might be going into the room to counsel before the parents have shared much with us, and we may need to kind of refer to the baby before they've had a chance to kind of lead that terminology. And I'm wondering if you would recommend kind of openly asking the parent or parents how they would wish to refer to their pregnancy or their baby.
I'm not a clinician, and I'm not entirely sure of the details for how to go about that, but I think what does keep showing up in research is remembering the human factor and just having conversations with the parents that have experienced the loss. And in those conversations comes out the way that they are viewing the loss, and things such as the baby name. And I would imagine that it is also fine to ask if the baby had a name already. Thank you for your questions, and also about being connected to Dr. Sharp. I have not yet connected with Dr. Sharp and the organization that you had mentioned, but thank you.
No problem. Thanks for your focus. Thanks for all the answers, and we'll connect to you. I can imagine the parallels there.
If we have time for one more comment. So I really appreciated your presentation, and I am not an obstetrician, but I am board certified in hospice and palliative medicine, and I see parallels here. So in the world of palliative medicine, at end of life and after a loss in the family, it is automatically part of the program to have grief counseling for at least a year after. So it's a completely different world, but I don't know if you've connected with the palliative medicine teams, and that same model, it seems to me, would be very reasonable to apply in this situation. And whether I have a patient who enrolls in hospice 3 months before death or even a day before death, it's still worthwhile, because that wraparound care is not just about the patient that's dying. It's really about caring for the emotional needs of the family. So I really, if it's not already happening, I would make a plug that sort of grief counseling for up to a year after just be part of the standard package of care. It doesn't mean I could make it so, but that's a thought I have.
Thank you so much, and I appreciate your comment very much, because I have the same perspective that grief counseling should be part of the care that we provide, and it should be long-term, because it's a very non-linear process. The ups and downs vary, and it should be person-centered also, because it varies from person to person. And the reason that I think of home visiting programs is because of my some research that I've done on home visiting programs, and I've just been able to see how home visiting programs are invested in the long term in children and parents and families as a whole. And so when a stillbirth happens, and we know that 2/3 of parents go on to have a future pregnancy and have kids, I am wanting to consider overall well-being of the family. And I had thought of home visiting again because of my experience, but what you have mentioned in palliative care, I think is certainly something I will look more into, because following existing models, I think is the way to go, because the evidence is already there for the effectiveness.
All right, I think that's all the time we have for questions. Thank you so much, Dr. Aguilera, and to our audience as well.
Thank you.
Good morning. I have the distinct pleasure of being able to introduce our researcher and community partner talk this morning, and that's going to be by Ms. Tia Murray and Dr. Kira Hoppe. It's really a pleasure for me to be able to introduce, as a clinician, I see that the work they're doing impacts my patients directly, and I think many in the audience here are probably noting the same, that we can really see the direct effects of their work, and are so grateful for it. So Ms. Tia Murray is a certified birth doula, certified lactation counselor, and considers herself a community-based doula. Tia was born and raised in Madison, Wisconsin, and always dreamed of giving back to her community. As a non-traditional student and single mother, she attended the University of Wisconsin-Madison and received her Bachelor's of Science in Community and Environmental Sociology. In addition to becoming a fellow in UW's Infant, Early Childhood, and Family Mental Health graduate capstone program, she also holds an Associates of Science degree as well as an Ethnic Studies certificate. Tia has passionately worked with women, children, and families in multiple capacities throughout her professional career. Her work has focused heavily on social justice, reproductive justice, access to culturally sensitive maternal child health care, and the promotion of community-based intervention and prevention programming. Tia has worked diligently with young children with disabilities or developmental challenges, has supervised home visitors, and has worked with women and parents struggling with homelessness, health issues, substance abuse, and mental health challenges. She strongly believes that it is crucial to meet families where they are at, to be curious and inclusive, and to provide culturally and socially sensitive support services. Tia, a mother of 5 beautiful children, continues working closely with parents, infants, children, and families to provide early intervention with respect to health inequities across the lifespan. In an attempt to meet a need in her community, she founded a community-based doula organization in 2014 that provides culturally sensitive and evidence-based pregnancy, birth, infant, and lactation support to mothers and families in South Central Wisconsin. And that's the Harambee Village Doulas. Ms. Murray is also executive director of the Harambee Birth and Family Center, a community-based maternal and infant health practice in Madison, Wisconsin, in collaboration with Project Babies and the African American Breastfeeding Alliance of Dane County. Her research interests include bringing greater awareness to the root causes of the residual impacts of racial inequities in maternal and child health. She is also interested in furthering research on the benefits of doulas on perinatal health outcomes, especially in communities of color. Dr. Kira Hoppe is a Wisconsin native. She completed her OBGYN residency and maternal fetal medicine fellowships at the University of Washington. She then joined the Department of OBGYN faculty at UW in 2015 and was promoted to associate professor in July 2021. She completed a master's degree in clinical investigation here at UW and is currently working towards completion of the PhD program. She has been the acting medical director of the Perinatal Center since January of 2018. She is board certified in obstetrics and gynecology and maternal fetal medicine. Dr. Hoppe is active locally, statewide, and nationally with numerous research projects and initiatives. She has led various research projects, has been published numerous times, and has active intramural and federal funding. Her research interest primarily focuses on pregnancy-related young adult chronic hypertension. She is committed to health equity and improving pregnancy-related postpartum and long-term outcomes for all people with hypertension. She developed a remote patient monitoring program with postpartum hypertension, which is termed the Staying Healthy After Childbirth, or STAC initiative, that has been successful locally and cared for over 3,000 patients. She is interested in how to optimize care for at-risk patients to improve healthcare engagement and overall health outcomes. Additionally, she enjoys participating in quality improvement and community education and is currently serving as lead physician advisor for Wisconsin Perinatal Quality Collaborative on their statewide hypertension project. So without further ado, we welcome Tia and Ms. Tia Murray and Dr. Kara Hoppe.
Good morning. Thank you for having us. Good morning. I'm so honored to be here. I've actually been coming for several years as a community member and thought how wonderful it would be to be able to present at this very symposium. So thank you very much for having me. Today, we hope our objectives will cover overview of our collaborative project, learning about the process of forming a partnership, and then the community partners' perspective on research and processes and benefits of structuring research this way. The name of our project is Advancing Postpartum Care for Black Women in Wisconsin by Engaging Community Partners with a Home Telehealth Service for Hypertension. It was a feasibility project. And Dr. Kara and I actually met over breakfast at one of these symposiums years ago, and probably twice. You know, there's layers of trust, right? As you're meeting with medical professionals and you're a community activist. And by the second time of us talking about the gaps we were seeing in our work as providers, we really thought that we could come together to do something about it and to have some action-based solutions on the ground collaboratively. So as most of us are aware, Wisconsin Black-white disparities are among the worst in the United States. Maternal mortality was 14.3 deaths per 100,000 live births in 2016, fivefold higher among non-Hispanic Black women. And infant mortality is even more astounding, so 6.2 deaths per 1,000 live births in 2016, which is a 3-fold higher rate in non-Hispanic Black infants. This slide really doesn't do justice with the depths of these problems, but it's just 2 astounding kind of facts to lay the groundwork. So we're going to dive a little bit into some clinical and community observations. So in the STAC program that we created, you know, when you're creating an intervention or you're trying to change the way we deliver a healthcare service or practice, it's really important that we don't create more disparities and that we're providing equitable care. And then when you put layers of technology on there, like, you know, are you, again, access, coverage, all these things that go with changing the way we provide care. And so in doing this, I'm constantly looking at like, how's participation, like, are there things we could do better? And I think as practitioners, many of you know, the reasons why we do things in obstetrics is often really not evidence-based, and there's lack of data and knowledge for why we do what we do. And so I've done a lot of work in looking at actual blood pressures reported, and I have like kind of a data gold mine. So, you know, look pre-pregnancy in this figure on the left, you can see blood pressures, and systolic is on the top and diastolic is the third one down. And I started, you know, looking at like, okay, so at pre-pregnancy through all the trimesters, at delivery, what happens when they go home? So there's really not a lot published about that, or there wasn't. And so this one is about blood pressures by race, but I have blood pressures by BMI, I have blood pressures by lots of different things, type of hypertension, et cetera. And then on the bottom, again, is the timeline. So you can see that with the white line on being Black, and then the Black folks being the blue line, that blue line being on the top is higher from pre-pregnancy all the way to the end. And the other thing you can see is towards the end at 6 weeks is that our Black moms' blood pressures are not recovering the same as everybody else's blood pressures. And so there are differences that we're seeing by race, and that's important in itself. But then I was like, okay, well, I want to make sure that this care program is delivering services to everybody in an equitable way. And so one way to look at that is like, how much blood pressure submissions am I getting, right? So I can look in that bar table by day 2, 7, 14, 30. And frankly, I ask for blood pressures every day, so I have it down to those fine details. And you can see this is just a subset of participation that included around 620 people, and that we have really high rates of participation all the way through 30 days. And then when you look at the differences in participation by our white and Black participants, you can see like they're very equitable at day 2 postpartum, but it's already extraordinarily different by day 7, and even like 50% less at day 14. And to me, this is unacceptable. So like that led to another effort of like, why am I seeing this? And so then it was talking to community members and focus groups and trying to figure out what are the gaps and what can we do different. And that's what led to like, we got to work together. And like, you know, starting at the people level and the community level is really important, because every patient matters and every patient has a different story. And so that's hence our relationship and kind of where we've gone with that. Sorry.
Definitely. And I think we also wanted to take a step back from the data and be able to enmesh ourselves in the lived experiences of those numbers, to really be able to know how to design an intervention, if you will, or maybe even something more preventative in respect to supporting Black women who are struggling from hypertensive disorders related to pregnancy. And some of those stories we shared together. As a doula, we don't do clinical things. We don't provide clinical care. However, oftentimes we have found ourselves on the front lines of the postpartum period, which is such a critical period where we will be the first ones a client or patient may call if they're not feeling well or they're experiencing strange symptoms. And there have been a myriad of occasions where a patient has called their doula, they're not feeling well. Either the doula isn't quite sure or they just send them to the emergency room. And sure enough, we have blood pressures through the roof. And not only do we have high blood pressures and all the challenges that come with that, but we also have a breastfeeding parent-child dyad. And then we have systemic issues that begin to be layered on top of that. Well, you must have somebody come get your baby because we need to take care of your clinical care. Well, what's happening with that breastfeeding relationship and that dyad? Who's going to come get the baby? And oftentimes it was a doula who was able to come and mitigate those situations. And so because of those gaps, which we can't necessarily mitigate as community-based doulas, our partnership is so critical to really filling those gaps in the continuity of care from hospital to home. And especially because most birthing folks aren't even seeing a provider who will check their vitals until 6 weeks. We know some of that's changing now, but this program is absolutely critical, in this partnership we really thought could enhance those outcomes.
So we're going to dive a little bit more on the community partners' perspective on the research and the process to get there. So for this project, we've already a little bit alluded to like what our goals were, but the immediate primary goal of this project was to align the efforts of healthcare and community providers through the postpartum period to address current gaps in postpartum care for Black women. And this is important, and I think for just contextual knowledge, I had originally tried to do some of this work in Racine as well, and some of you may know about that. And, you know, Dr. Sarto's in the back and she's from Racine, and so I talked to her about this in the past. And I still feel very deeply committed to that too, but like learning in that community they had tried for years as community partners to be involved with the healthcare system and they just weren't welcome. So it's some of us being open to like what the community has to provide because it's instrumental in the care and the ability for people to access care and participate in their healthcare.
As I mentioned, the postpartum period is so critical in respect to the continuity of care and really thinking about preventative care. But there's also this problem of, well, whose problem is it after the baby's born? A lot of us are scratching our heads about the fact that nearly 97% of pregnancy-related deaths in Wisconsin were preventable. That says something. And so, but whose responsibility is it, right? The baby's born, we've done our job, the family goes home. Whose responsibility is it to make sure that needs are met, that readmissions are reduced, and that hypertensive disorders in particular are addressed in an equitable fashion? But as I mentioned, this partnership really helped build that bridge to continuity of care. And we really saw that in a lot of our outcomes, both quantitatively and qualitatively. And there's a quote here from one of our participants in the project that said, knowing that I was not alone, the breastfeeding support was great. It was great to have a community who would support me. And we really hope that this can be the experience in the case for all Black women birthing, but all folks in general who have birthing bodies. And so we're hoping that we're really setting the tone and setting an example for further work we can all do together. A few things we wanted to highlight. Oftentimes, I think forming the partnership and the collaboration, that process is much more informative than the quote unquote research, especially when we're working with community partners and we're looking at addressing racial inequities. Because what happens is we tend to individualize the problems through our research, and we're trying to figure out, well, why don't these Black women participate? Why aren't they taking their blood pressures? We're asking some of the wrong questions. And oftentimes we're not looking at our own processes, institutional processes, our processes as providers as well. And so for our partnership, intentionality mattered every step of the way, from creating the recruitment video, where we thought it was important for participants to see both of us as researchers, but also as a community activist, so that they saw themselves in the project as well. And to use language that wasn't researchy, for the lack of a better phrase or word, so that they could relate to the importance of participating in a project like this. And so representation on the research team really mattered in reflecting the target community that we were really looking to serve. And again, we had a beautiful multidisciplinary spread of providers because of the nature of our clinical and community partnership. We had OBGYNs, hospital-based nurses, we had community nurses because we are privileged to have that at Harambe Village doulas. We had doulas, lactation counselors, researchers, community scholars, and Black mental health professionals. And we really felt that it took a multidisciplinary lens to really wrap our arms around Black women in this critical period to make sure that we were really addressing all of the health-related social needs that might come up. And another important fact is reciprocity in a clinical community partnership. You've probably heard a lot about helicopter research, but we'd rather see a reciprocal partnership. What is it that you're bringing to the community and that will stay in the community? We don't just want to take from the community. And so we were able to develop those things along the way, both within our own internal partnerships and relationships, but also in the products and the outcomes that we produced. And again, sustainability matters. We can do 1,500 pilots, but what are we going to do with that information? And what are we creating to leave behind so that that good work and that impact can have a long-lasting effect?
Additionally, this wasn't always easy, and that multidisciplinary team took us a lot of work. And I think both of us underestimated the amount of time, but even breaking down what are our roles, what do we do, how do we talk? And it's led to like a nice weekly 15-minute check-in that like is absolutely essential. And I can just say like communication, respecting boundaries, respecting what
Yes.
each of us do in all of our roles has been very helpful.
Absolutely. And I think that's important to highlight. It isn't always easy. And the fact that we can share those challenges, I think actually will inform a more robust intervention, if you will. And I think an example of that is, we've all probably heard about doulas, right? They're really sexy. There's a lot of grant funding tied to it. Doulas are great. And I think we oftentimes think we can just throw doulas into the equation and everything's going to be better. Yes, doulas can impact outcomes in a positive way, but we are not the silver bullet. And I think what happens and what's happening in our local healthcare ecosystem is that we think we can just add doulas on and we're going to just get these amazing outcomes without really addressing the issues, barriers, and challenges that are producing the very outcomes we are trying to address. And with this partnership, it allowed doulas to stay in their non-clinical role. So I had a patient who gave birth, a young Black mom, and she actually developed eclampsia during labor. And then she unfortunately had to get a C-section and she seized immediately after. And so she had a myriad of complications in the postpartum period. She happened to be enrolled in the STAC program, which I didn't know about at the time, but it was a relief to know that she was being monitored and she had that resource and support to help with those complications she was having from what she experienced. Well, we were able to focus on a lot of the other social determinants of health or other needs that she had. Like breastfeeding support, right? When you're put on a magnesium drip, there's so many challenges to sort through. But this partnership really allowed our doulas to stay in their non-clinical role. Of course, it took some time to help each other understand what our roles are in this project. And so it allowed them to do things that were non-clinical while the clinical team was able to address all of the clinical matters.
And when we had problems clinically, we were able to lean on our partners the other way. Like, what
Exactly.
is it? Like, oh, by the way, they don't have a phone, or, oh, by the way, like, you know, so that was very helpful back and forth.
Exactly. Exactly. So we saw that it was mutually beneficial. And in addition to that, the participants also saw people that looked like them. We intentionally placed a Black nurse at the forefront of the project so that she understands the doulas, the needs of the doulas, the community, but she also understands the hospital clinical labor and delivery setting, and was able to really act as a liaison between the community and that of the clinical and research team, while also supporting the doulas on the ground and letting the doulas just do their work. And so I think because of that, we did see a higher interest rate, a higher retention rate, because they're seeing other people that look like them and understand their lived experiences. And again, I think most importantly, our partnership really did expand that health equity lens to look beyond reactive care. So enrolling people after the fact and thinking about how can we support hypertensive disorders related to pregnancy so much earlier on, or can we even prevent them from happening? And so I think that is almost more important than the sort of reactive approach that we oftentimes take in a healthcare setting. We all know that relationships matter, right? And they last a lifetime. And one example is, even just because of our relationship established through this partnership, I will text Dr. Happy when I have a client who is like, these blood pressures aren't looking right, but she's not being listened to. What can we do about this? What are you seeing clinically here? How can we support her? Who can you connect us with? And that's outside of the project. And so I think even the relationships that were built are really going to help close a lot of those gaps, particularly with the families that we serve, and hopefully we can expand that in the community as well. I did already talk a little bit about the roles between the research team, the clinical nurses, and how we had that interplay of liaisons. I myself am a graduate student, so being a Black community scholar was able to really go between both worlds, if you will. And I think it really helped to support the community organization in understanding the importance of the research and why we're doing it, and then bringing that community perspective back to the research team to really, again, have that reciprocal information sharing and those mutual benefits. And we know that community perspectives matter. We all know that, but how are we elevating that? I think is the question. How are we bringing that to the table? How are we acknowledging that as trusted evidence-based information? And again, this goes back to what I was saying earlier, is that we also need to understand doulas, if we're going to partner with them, and really understand that healthcare systems also have to do the work. Right? And we were seeing gaps in labor and delivery care that we were kind of cleaning up after the fact. And so we had to talk about that as a team. And what can we do to really be intentional at every step of the project? I think these slides really highlight a lot of the things that we discovered along the way as we were building that process of communication. How do we communicate? What is your scope of work as a community-based doula? What is your scope of work as a clinical nurse? And a lot of things came up. You know, systems really have to be flexible and willing to hear where the gaps lie within their own institutions, instead of, again, individualizing the problem as we talked about earlier, because we need both of those things. We need the change to happen at all levels while supporting the individual on the ground. And we talked a lot too about themes that related to this idea of race-based medicine versus race-conscious medicine, right? And as a midwifery student also, I'm learning a lot about the pathophysiology of things like anemia, preeclampsia, hypertensive disorders. And when you hear things like Black women, if you're Black, it's a risk factor. Well, we have to think much more critically beyond that. What exactly does that mean? And there was an example that came up in our work where our nurse was triaging what was happening with this woman's blood pressure medication. And it turned out she was seeing a trend that Black women weren't responding as effectively to a particular blood pressure medication that's kind of blanketly used. And so we were able to tweak that, and we got much better results. And so it was those things that the community was able to bring to the clinical space that really helped inform how we will approach the project going forward. And again, the ability to connect the data dots, as I would call them, and really see the bigger picture. So we had one slide that highlighted the data about maternal mortality, Black maternal mortality, and Black infant mortality. But we hit that over the head so much. But what we aren't doing is really connecting the dots. We know that things like anemia, preeclampsia, hypertension carry risks of low birth weight babies, of preterm births. Those are also leading causes of Black infant mortality in this state. Are we really connecting the dots? And this project and partnership, I think, really is laying a roadmap to be able to do that in a much more intentional and equitable way. And just highlighting too, some of the challenges that we did have as a community partner was really protecting the doula model of care. Like I mentioned earlier, they want doulas to do everything, but we have to stay in our lane and do what we're good at. We're not OBGYNs, we're not nurses. And when we can stay in our lane, when we can stay within that scope of work, the efficacy of our work is that much more robust. And I think understanding too, with research funding and research projects, is oftentimes community-based organizations are working with very limited resources. And I think that gets forgotten about when we're designing the way in which we disseminate and distribute that funding as well.
One thing I just want to reflect on that is like, we open this project, right? And we get like 10 referrals in a week. And they're like, what? You know, like, we're like, oh, well, we're great. We're like recruiting all these people. And you're like, no, like we've got to, you know, pace this. And so it literally, you know, that was a process. Like, it doesn't seem like something that'd be so complicated, but like, then we set limits and we set barriers. And like, at the end of the day, we have a very like, we can take this many people, we can do this, because if you don't do that, the quality of care you can do when you're dumped a high load is actually not as good, you know, as it could be when we're like conscientious and careful about the care we're delivering.
Exactly. So there was a nice balance between let's get the numbers for the research project, we have a time limit, versus how can we also respect and support what the capacity is of this community organization operating with limited resources.
And even to the place where like, hey, I'm going to be on vacation. Hey, I've had this life situation, like this week, we can't do that. And so we were to that level of like, just being really respectful about those boundaries, which I think is important.
Absolutely.
Anything else? So results, some preliminary results of our partnership. We, you know, we're nearing the ends of this project. Our funding is done at the end of this year. And it's taken a village. We already talked a little bit about our main partners were Harambe Village, the STACK team, and then we've had a couple of different mental health therapy groups that we tried to incorporate in this. This has been really, really challenging. When to start this, when to provide group care, then COVID hit, so we've really not been very successful, but our vision of that was to bring women around the same birth periods together to really like debrief and talk and support each other, you know, every couple of weeks, those first 6 weeks. And I still think this would be amazing, but we've just really had a hard time getting it going. And then we had qualitative evaluations with Susan Passmore, who some of you may know. And really the overarching goals were a few. So to advance postpartum care for Black women in Wisconsin by engaging our community partners, we hoped that it could augment the hypertension care and management that we're providing, that community-based doula care would also be like really instrumental in lactation counseling and supportive care, social support kind of care, which would lead back to their any woman's or person's ability to like engage with healthcare better. And then again, this third element of group and peer support or individual mental health therapy if needed. So that was sort of like our overarching plan.
And I did want to highlight too, Dr. Hoppy, that we weren't able to implement the project until we were like smack in the middle of the pandemic also. Yeah. So it was in some ways, I think, an advantage to these women and birthing folks because we had that telehealth component of the project that already existed. And we also know we've seen some interesting trends in birth outcomes during the pandemic as well, more C-section rates. We know there's much more complications from that, particularly for Black women. And so I think that'll be interesting to look at as well.
One thing to just touch on here, like from the very basics of this, we didn't even know, like, could we share patient level information? So going through HIPAA approvals and security contracts and these types of things, we've been able to accomplish that, which I think is huge.
Absolutely.
We've also created a hypertension doula kit. So I have a STACK program doula kit for like other institutions to implement a program like STACK, but we felt like one of the things I've heard in some of the initiatives I've done is that doulas are the frontline people. And that's sort of what that little quote says up there. It's really small and I'm sorry. But like if clients or persons are approaching them, we need to uptrain the doulas at least about the clinical awareness of hypertension. And so this doula toolkit goes through definitions, it goes through common questions they may get, standard answers they could provide without them overstepping this clinical role that is not really their position, but enhance the care because they're more educated, right?
Absolutely. And again, we don't do anything clinical as doulas, but having more clinical knowledge helps us support higher risk pregnancies or pregnancies that have more complications. And another, I think, unmeasured outcome of this project is from the recommendation of our Black nurse who's here in the back. I have to give her a lot of credit. And Dr. Hoppy, they came together to put together a module around hypertension for our doula training that we provide to community members, even other healthcare professionals. And so I think that'll go a long way in really supporting the tool bag of our community-based doulas now and into the future.
Yeah, that's actually a screenshot of Nursuno and I like recording our sessions so they can use this when they're training people in their doula training. This is just a really quick chart, and I know we're getting close to the end of time, but it's just to show you, I started with saying weeks postpartum and the amount of participation we're getting per days of blood pressure results. And on the far left is just like baseline data of over 1,000 people, showing that like we get, initially like a lot of days per week, 6, almost 6 all the way through, midway and blah, blah, blah. Those are days per week that we get blood pressure vitals, right? So then there's white folks that don't have a doula. There's Black folks who don't have a doula. And then as you get to the other side, you're seeing there's Black patients who now have a doula. And what I did was show you that when you look at the Black patients who don't have a doula versus having a doula, we have a significant increase in the amount of blood pressures per week that we're obtaining. And furthermore, when you look at white patients without a doula compared to Black with a doula is also statistically significant. Not all the way through 30 days, but at least in those first 20 days where like a lot of the problems happen. And this is very exciting.
Absolutely.
We also have been working on some qualitative assessments, as we sort of alluded to, and we just wanted to share a couple themes that we're getting, one from the healthcare perspective and one from the patient perspective.
Yes, and for the sake of brevity, I'll just read one of them. So I felt like this program honestly saved my life because I really wouldn't have been getting my blood pressures checked or anything after having the baby until my 6-week checkup. So the 6 weeks I was at home, going through the postpartum healing from the C-section, I felt like this program really was very good for my health and my well-being because I wouldn't have been knowing which medicines to switch or add on or take off.
And then just from the emotional kind of support doula perspective.
I really enjoyed like having a doula this time around because she supported me through a lot of stuff like other than just my blood pressure. So I really enjoyed that part.
And there's a lot more.
So I think, yeah, again, just highlighting the themes that we shared from the participants' voice.
So in conclusion, overall participants have reported their experience in a very positive light with physical health being supported as well as emotional health being supported. And with that, I don't know if you have any closing thoughts.
Relationships matter. And thank you for this symposium. My hope is that we will get more community representation to come here, more doulas, more folks on the ground, because here we can also develop relationships that can last a lifetime as well. So thank you.
And I just want to say we've taken, 45 plus people, and each one of them have a story, and each one of them are different. Each one of them have their own barriers, facilitators, and working with phenomenal people and boots on the ground like has really impacted my life and really opened my eyes to what's actually going on with our patients. So thank you.
I'm just going to facilitate questions. So if I can, anyone in the room, and then we'll keep an eye on the chat too. Yes, Dr. Northington Gamble.
I just want to applaud you for such a great presentation in many ways. Just in terms of the importance of community engagement. But there's one thing that I'd like to hear more about, and it was only briefly touched upon, and that was layers of trust between the two of you. Because it was just, because in order for this to happen, and I've talked a lot about trustworthiness and the importance of that and respectful, but just how you laid it out. But the important thing is even looking at the two of you present, was I think important. But in terms of getting there, you two had to go through some challenges to deal with, as you put it, the layers of trust. And I think that would be very useful. Yeah. I'm sorry.
No, I mean, that's a fantastic question. That's where it all started, right? And I did mention that we met the first time. I think she had mentioned it. I was kind of like, is this the same old thing? Is this somebody that's really, wanting to work with us in a reciprocal, respectful fashion? And it took meeting a second time and much more after that, again, having the role of being on the research team with Dr. Hoppy. We met quite often and we discussed some tough and difficult topics. And I think because we were able to build that relationship, we were able to mirror that as well in the partnership. But that's a very critical, important question. And I'm glad you asked that. We didn't touch on that a whole lot, but it also does mirror sort of the, I'm going to say, unearned trust as opposed to lack of trust that we have in our communities, particularly our communities of color and that of the healthcare institution.
Yeah, and I'll just say, like, you know, as a white person, like, I can't change the way I look or who I am, right? But I genuinely care about caring for everybody and having health equity. And it's taken years to actually be able to be in this position. And I feel honored every day and learning how to be respectful about it. And sometimes I'm like, I don't really know if I'm saying this right. Like, correct me if I'm wrong, but like, just being humble and like knowing that I don't know everything and I'm willing to be corrected and putting myself out there is like not always comfortable. But I feel rewarded in it every day. And I just want to keep fighting whatever fight I can help fight, you know?
Yeah, and I think it's been 4 years now that I look back. But I also would applaud Dr. Hoppy, you know, because of things we were able to talk about during the project. She would even go sit bedside by some patients and want to understand things better. And I think that's an example of how we can be better providers when we hear things that may not sound well or feel very comfortable, but she was willing to dig deeper and see what she could do in her role in those situations as well.
Yeah, one really important story, you know, and I called Nurse Uno about it, was I sat at the bedside with this patient and was like, you know what, I don't know if I should ask you or not, but like, why don't you want to breastfeed? And it opened up this entire conversation of like, well, I have this extenuating trauma. And like, we went on and on, and I learned a lot, but I was also like, she's being discharged with a baby in the NICU who's bottle feeding. And then like learning, like sometimes our patients actually are just not even being offered donor milk. Like, why are they getting donor milk? They're all supposed to get donor milk. So I worked with Nurse Uno and she was able to then approach the patient in a very different, more like trauma informed way. Like, yes, you have this trauma, but like, let's talk about this. And she breastfed, which is really, really cool. But every one of us that's at the bedside and too busy, like I had to sit down and I had, you know, to give some of my time of the day and really know that I don't know how long it's going to take me to get to this point, but like taking that time, you'll make a difference. Again, one patient at a time. Huge, huge difference.
Yes, Maya, please. I think this will probably be our last question here.
Okay. You sort of just mentioned it, but I was going to ask about kind of like the feasibility and timeline of creating a project and a partnership like this. Obviously, Dr. Hoppy, you're here on a long-term kind of permanent appointment, and for someone that's a trainee, projects like this can be so impactful but seem kind of out of your scope. And if you guys could talk about how long this has taken you to get to this point and just touch on that.
I think that's a great question.
Yeah.
I think any advice you might have for residents. I mean, they're here for 4 years.
Yeah. Do you want to talk a little bit about the timeline?
I mean, I just feel like I've been working towards this since 2015. I mean, I've had multiple conversations with Dr. Sarto, like, how do I do this? I've had mentors across campus, like, I feel defeated, like, I really want to help, like, be patient, this takes time, you know, and really just continuing to be there. And whatever community you might land in, like, you've really got to be dedicated, and it has to be apparent that you're not, you know, there for your gain, and that you're there to work together and to advance things. That might take a decade, you know what I mean? But in a short period of time, I think you can make large impact in things. One of, you know, your project today on aspirin, like those things are very impactful. And so I think you may not, I don't know how to advise, which I think maybe Tia might have a better way to do that, about like actual patient relations or community partners. But maybe if we get something going, like we could do this on a more regular basis, because you have established trust within our department that then might make resident involvement, you know, easier. But otherwise, I think even small projects that like you did, for example, are impactful. You know, it's like what you do with the results.
Yeah, that's where it's at, is what do we do with the results? How are we translating what we all know and we've probably known for a long time into the community, into actionable solutions? And I think that's where it's at, and that's where it matters.
So say if like our residents found something and they wanted to contact you and be like, hey, we need your help. Like how would you suggest they do something like that? Like with that?
Well, we've worked with several residents and we are, and it always looks different. We're always sad because oftentimes they don't stay and we'll start something so beautiful. And so I think, obviously it depends on what it is, but I think as much as you can bring an offer to the community, like I think residents get maybe like a day or two of community involvement or engagement. It should really be infused into the curriculum so that the community knows it's always going to be there. And then we can work more intentionally with particular organizations or community members.
Thank you so much for your talk and all of your great wisdom this morning. We're really grateful. I wish we had more time to continue, but maybe offline we can reach out as needed. So maybe just one great round of applause for. I do have some announcements to make. Transition to this one maybe. So we have exciting winners to announce from our posters and our brief and brilliant talks this morning. But before I jump into that, a big thanks to our judging and team that was working very hard behind the scenes. So that's Anastasia Dowdy, Doctors Madeline Green and Jenny Higgins. So big thank you for your hard work in selection. And so I'm going to start with our brief and brilliant winner, and that is Megan Murphy-Belcaster for her presentation on delivering method trends for American Indian mothers over 2 decades in Brown County, Wisconsin. And then for our poster winners, we have 2. And the first one is going to be accepted by Dr. Heidi Brown. And for the first author, Madeline Morrow. While we don't have anything to hand out for our winners today, we're going to connect you online and through email for your monetary awards. That presentation was, poster presentation was Zoom to Scale, Real World Implementation of Online versus In-Person Community-Based Continence Promotion. And our second poster winner again goes to Megan Murphy-Belcaster for trends in VBAC versus repeat C-section rates in Brown County over 2 decades. So again, a big round of applause for our 3 winners. And I just want to also point out, I recall hearing that Megan Murphy-Belcaster was going to be an OBGYN and is a medical student. So a huge plug to our learners, our students and our residents about what kind of impact you're able to make in healthcare and in the community. So thank you. And then, so just a big thanks for today and for all of our speakers, for all of our attendees. We're really grateful for everyone and we had a great morning. Thank you. And we look forward to hopefully seeing you again next year.